Doug, the floor is yours.
Thank you very much, Dow. It's a real pleasure to be with you guys tonight. Thanks to Aspen, Tim, and our great moderators for putting this on. This is a very exciting time for me. Tonight, I will present to you the results of the Viadisc trial. And the Viadisc trial is a large triple-arm randomized control trial. And this is data from this randomized control trial enrolling patients with discogenic back pain. And so this includes patients with discogenic back pain that is the Fearman grades 3 through 6. So this is moderately degenerated, not normal, not the kind of discogenic back pain that would give rise to vertebrogenic pain that was mentioned earlier. So without further pomp and circumstance, let's jump right into it. So this is in 215 patients. This is visual analog scale improvements between 35 and 45 points for the active allograft, seen in the line that I perceive as purple, and then the crossover to active treatment and the green dashed and dotted line. The placebo, and the placebo's in air quotes, and that was used as saline, is on your left. And the reason why a lot of us are really excited about this stems from the data the Corey presented earlier, and this is the Wu meta-analysis that said, on the average, if you take the 6 trials with a grand total of 74 patients, the improvement in VAS was a fairly profound 44.2. I mean, that's as good as many things that we will test. And we have almost an identical improvement in Oswestry Disability Index of 27 to 36 points, keeping in mind that one category is 20 points. This is almost a category and a half. And we see the 3 placebo, active allograft, and the crossover to active treatment lines paired out just the same as they were, almost identical in the Viadisc trial, and we can compare that with the Wu meta-analysis of 32 points. And so this compares not only favorably, but very favorably. So one of the issues that was discussed previously by Corey is 1 versus 2 levels. So all of the trials that have been mentioned, all of them except for one, and that's the Biostat trial, used 1 level. And I can understand the use of 1 level, trying to decrease the number of compounding variables, trying to get the data to be very clean, trying to get it to be isolated to discogenic back pain. I understand that, but if you look at your own practice, how many single level discogenic back pain patients do you have? Well, they're not rare, but they're unusual. They don't come along very often. How many patients do you have in your clinical practice that is 4, 5, 5, 1 level discogenic back pain? Well, you can probably think of a number just off the top of your head. And so this compares 2 levels with 1 level, because 2 levels were allowed in the Viadisc trial. So when you look at the data in the active allograft and the crossover, not only did the 2 level patients do well, they actually did better than the single level patients and different from the saline patients. And they did better than the 1 level patients, not only in the visual analog scale reduction in back pain, but also in the Oswestry disability reduction in back pain. So this was designed at the very outset by Chief Medical Officer of Viadisc, Tim Gainey, who's excellent in designing trials, and we had this discussion. We wanted to make it as close to your and my clinical practice as possible, and I think we've accomplished this. And it turns out we got a better treatment outcome treating 2 levels rather than just 1. So one of the marquee data that Kaz just presented was the mesoblast, and that's what data got a lot of us very interested in regenerative treatment for discogenic back pain. And we see here the 2 high responder groups, meaning patients with no back pain is defined as less than 20 points on the VAS, or less than 2 in the numerical rating scale. And then people with a profound reduction in back pain, meaning cut the back pain in half or more. And this was kind of the marquee data for mesoblast, because 69% of the patients with the mesoblast data had their back pain cut in half or more. And as good as that was, and as much interest as that generated in phase 2, the Viadisc trial is very comparable to that. And the patients from the mesoblast that had their back pain cut in half was also comparable. And the Viadisc trial did not suffer by comparison of this, between up to 59%, and the allograft crossover ended up with no back pain as defined by less than 20. So as we go on to the prominent responder group, what we did find is that in the responder group that was a high responder cohort, 91% in the crossover group had a greater than 20-point reduction in back pain. And this is the single point in the visual analog scale pain reduction that was statistically significant. So we've now seen statistically significant reduction in pain, at least in this responder group, the high responder group. As compared to the Oswestry disability, we measured it. The MCID was greater than 10 points. One of the FDA standards was greater than 15. And then we also measured it greater than 20 points. And so we had statistically significant reductions. I have up to 10 and 15 points there. It actually turns out that all three groups were statistically significant. And with a 15-point or greater improvement in Oswestry disability, keeping in mind that 20 is a full category, we had up to 78% of patients that experienced this degree of functional improvement as compared with the mesoblast data that was 50%. So I'll present to you Oswestry, functional improvement, and then VAS improvement. And we had 53% in the active allograft and 64% improvement in the crossover to active treatment with the Viadisc cellular allograft. We can compare that to the Relievant decrease in pain of 46.7%. We also have a decrease in back pain of 54 and 50 and 65% respectively for the two groups, and keeping in mind that the Oswestry disability was 53 and 64, and this compares with the primary endpoint in the basivertebral Relievant SMART trial of 41%. And one of the reasons we keep mentioning the comparison to the basivertebral SMART trial is a couple of different reasons. Number one, it's a large trial. The SMART trial is 225 patients as compared with 218 patients in the VAS trial, so very similar. The other one is vertebrogenic pain. We mentioned this earlier. Vertebrogenic and discogenic, they're different patient populations. I agree completely with Dr. DePalma, because on the average, discogenic pain are young, healthy people. It's on the average 36 years old, BMI of 27, and the basivertebral nerve ablation will be about 53 years old. So these are different patients, but they're comparable in terms of location and clinical presentation. So large trial, and it also compares with the sham. So the sham here is 32% reduction in pain and just docking the needles, which is a profound one compared to data by Hoffman and Levine. They said between 10 and 20% is about the normal, but nevertheless, basivertebral nerve ablation was significantly better than the sham. But we can see between 54 and then 65% of pain relief was obtained with the Viadisc cellular allograft, quite a bit better. One of the things that's also interesting in the VAS trial is the, in air quotes, the placebo or the saline injection. So the saline injection in the VAS trial had a whopping 45% reduction in pain. And as good as that reduction in pain was for the basivertebral nerve ablation trial at 32%, it was beat handily by the reduction of saline. And interestingly enough, compared to the basivertebral SMART trial, ablation SMART trial, the saline in the VAS trial, our placebo, had a better clinical response in terms of pain reduction than the active treatment in the Relievant SMART trial. So I want you to let that sink in for a little bit. And it also emphasizes our point that saline is not a sham. It's an active treatment. And from my opinion, at least we got a better result from the cellular allograft treatment than the saline. I'd like to show you a few clinical examples. These are things that I'm an interventional radiologist, and as a radiologist, I rarely, if ever, see. We typically don't see modic type 1 degenerative end plate changes go away, and this was seen 1 month after injection of Viadisc. We typically don't see the improvement of signal within the disc, as we see in this patient 6 months post. And as I mentioned this, I'll call your attention to the VAS and Oswestry scores under there. And as nice as it is to see improvement on the MRI, it's even nicer to see clinical improvement, which that's where the rubber meets the road. We also see at this L5-1 disc, we see the modic type 1 changes go away. We see reestablishment of signal within the disc, and we see a cleaning up, a shoring up, a tightening of the posterior annular fibers. And we can see that not only in one level, but we can see that in two levels, especially this 5-1 disc, where the posterior portion tightens, and the disc disruption at the posterior portion seen at the 5-1 on the left is no longer seen at 5-1 on the right. So you have some disc morphology changes as well as disc signal changes. And as Tim Gainey says, all roads lead to Rome. It's not quite the case here, but this is an algorithm that's actually pretty simple. Nobody cares about Fearman grades 1 or 2 because they're normal. Fearman grades 7 or 8 with modic changes are the territory of basivertebral nerve ablation. And if the discography is negative, nobody cares either. And then once you get down to a moderately degenerated the degree of Fearman scale that is confirmed by discography, this is a territory of regenerative medicine injection. So finally, we have a low back pain treatment algorithm that's something more than, as my colleague from Jersey calls it, 3 whacks in a back, meaning 3 epidural injections and a fusion. We actually have things that have level 1 evidence that show their efficacy. So in summary, we have the Viadisc is not only the largest, but it is the only trial for regenerative injection into the intervertebral disc that have sustained benefit at 12 months. And those sustained benefits are functional improvement and improvement at least one pain responder group. And hopefully this is not an arcane trial where you have to pick a single clinical level. This is designed and has shown better outcomes in 2 levels even than 1 level. So hopefully this is highly clinically applicable. And with that, I would like to say thank you very much for your attention, and thanks to Viadisc for sponsoring tonight. I'd like to turn it back over to our moderators.
Doug, we have time for one quick question before we go to our last speaker, and we're certainly appreciative of your talk. It was really great, as you always deliver great information. My question is this: you said all roads lead to Rome, someone told you, but in West Virginia, all roads lead to reimbursement. So what I mean by that is, if you don't get reimbursed, you aren't going to do any of this, right? So will this study you just presented, if it leads to FDA approval, lead to me being able to offer that to my 45-year-old patient with discogenic disease?
Yes, good question, Tim, and the answer to that is defined absolutely. Build a little bit on what Corey Hunter said. The Class 3 code has already been awarded. So this has a level 3 code, and we're applying for code 1, and this study is part of the 5 clinical elements that will be necessary for the level 1 code. So what we're doing is we're categorizing this as data for randomized controlled trial. The next study is called the ASAP trial, and this is comparing it not against a non-placebo placebo, but this is comparing it against non-surgical management or conservative care, however you would like to term it. And this is part of an amalgam. We're going to combine this with registry data and other portions of that 5 pieces of data to attain the level 1 coding. So this is part of the progress. We're on the road, and hopefully we'll be there soon.
That's so helpful, and thank you for all the work you're doing. I think it'll help a lot of patients, and we appreciate it. And your answer just now leads us to our next speaker, who will talk about integrating our practice. So Dawood.